Hello and welcome. Today we're diving deep into a rare but serious autoimmune kidney disease called anti-GBM disease, also known as Goodpasture's syndrome. We'll explore what causes it, how it affects the body, how it's diagnosed, and what treatments are available. This is a condition that demands attention, so let's get started. So what actually causes anti-GBM disease? Well, it's an autoimmune disorder. This means the body's immune system, which is normally designed to protect us from infection, mistakenly attacks its own tissues. In anti-GBM disease, the immune system produces antibodies that specifically target the glomerular basement membrane, or GBM. The GBM is a crucial part of the kidney's filtering units called glomeruli. While the exact trigger for this autoimmune response is often unknown, certain factors like genetic predisposition, environmental exposures, and infections may play a role. Exposure to hydrocarbons, certain medications, and even viral infections have been implicated in some cases. Smoking is a significant risk factor, greatly increasing the chances of developing the disease, particularly in those with genetic susceptibility. Now, let's delve into the pathophysiology, which is how the disease actually develops. These anti-GBM antibodies bind to the glomerular basement membrane in the kidneys, and in some cases, the basement membrane of the lungs alveoli. This binding triggers an inflammatory response. The antibodies activate the complement system, a part of the immune system that leads to the destruction of the GBM. This destruction causes damage to the glomeruli, impairing the kidney's ability to filter waste products from the blood. This can lead to rapidly progressive glomerulonephritis. When the lungs are involved, the antibodies damage the alveolar basement membrane, causing pulmonary hemorrhage or bleeding in the lungs. The severity of lung involvement varies, but it can be life-threatening. Anti-GBM disease is relatively rare. It affects men and women equally, although some studies suggest a slightly higher incidence in men. There are two peak age groups, one in the 20s and 30s, and another in the 60s and 70s. This suggests that different mechanisms may be at play in these two groups. Its prevalence is estimated to be around 0.5 to 1 case per million people per year, making it a rare condition that requires specialized expertise for accurate diagnosis and treatment. The signs and symptoms of anti-GBM disease can develop rapidly, often over days or weeks. Kidney involvement typically manifests as fatigue, swelling in the legs and ankles due to fluid retention, foamy urine indicating protein loss, and high blood pressure. Patients may also experience decreased urine output. When the lungs are affected, symptoms can include shortness of breath, coughing, and coughing up blood, also known as hemoptysis. If left untreated, the disease can rapidly progress to kidney failure and respiratory failure. Diagnosis of anti-GBM disease involves a combination of blood tests, urine tests, and a kidney biopsy. Blood tests are used to detect the presence of anti-GBM antibodies. Urine tests can identify protein and blood in the urine, indicating kidney damage. However, the gold standard for diagnosis is a kidney biopsy. A small sample of kidney tissue is examined under a microscope to confirm the presence of anti-GBM antibodies bound to the glomerular basement membrane. In cases with suspected lung involvement, a chest X-ray or CT scan can reveal pulmonary hemorrhages, and bronchoalveolar lavage can confirm the presence of blood in the lungs. Anti-GBM disease can be broadly classified into two main forms. Goodpasture's syndrome describes anti-GBM disease with both kidney and lung involvement, characterized by glomerulonephritis and pulmonary hemorrhage. Anti-GBM glomerulonephritis involves the kidneys, but without lung involvement. The distinction is important, as lung involvement often indicates a more severe and rapidly progressing disease course. Treatment for anti-GBM disease is aggressive and aims to suppress the immune system and remove the harmful antibodies. The primary treatment modalities are plasmid exchange, also known as plasmapheresis, and immunosuppressive medications. Plasma exchange removes the anti-GBM antibodies from the bloodstream, while immunosuppressants like corticosteroids and cyclophosphamide suppress the immune system, prevent further antibody production. In some cases, rituximab, a monoclonal antibody that targets B cells, may be used to further suppress the immune system. Dialysis may be necessary to support kidney function if kidney failure develops. Early diagnosis and prompt treatment are crucial to improving outcomes. Currently, there's no known way to definitively prevent anti-GBM disease. However, avoiding risk factors like smoking and minimizing exposure to potential environmental triggers may help reduce the risk, especially for those with a family history of autoimmune diseases. Early recognition of symptoms and seeking prompt medical attention are also important to allow for early diagnosis and treatment, which can improve outcomes. The prognosis of anti-GBM disease depends on the severity of the kidney and lung involvement at diagnosis, as well as the timeliness and effectiveness of treatment. With aggressive treatment, some patients can achieve remission and recover kidney function. However, many patients still develop chronic kidney disease, requiring long-term dialysis or kidney transplantation. Factors that worsen the prognosis include severe kidney damage at diagnosis, the need for dialysis at presentation, and the presence of lung hemorrhage. Recent research focuses on identifying genetic markers that may predict susceptibility to the disease and developing more targeted therapies that minimize side effects. Studies are also investigating the role of specific immune cells in the pathogenesis of anti-GBM disease, which may lead to new therapeutic targets in the future.